thank the organizers for inviting me, particularly Francisca and Maurice Chaumet. Thank you as an American for being able to crash your European party here in psychiatric genetics. It's an honor. So, as Francisca mentioned, I've been a genetic counselor for many years, primarily in the world of neurodevelopmental disorders, back in the days when we used chromosome karyotyping with a 3% diagnostic yield, and nobody blinked an eye back then. So it is very interesting to be in the psychiatric world, and particularly when we talk about adult psychiatry, where there are many more concerns about utilizing genetic diagnostic testing. So because I'm not a psychiatrist and I'm coming at it from the sort of clinical genetic counseling aspect, I am not constrained by any preconceived notions about what should be tested for in adults or children. I can tell you about my experience, and I'll tell you a bit about a project that we're doing over in the States where we're actually returning copy number variant results to adults who are part of our large population health project. I should mention I have a few disclosures to make. And I wanted to clarify, too, it's obvious to many of you, but maybe not all, you know, there is some confusion I've noted in the, particularly in adult psychiatric world, among clinicians, among the different types of genetic testing. And so there's pharmacogenomics, of course, for drug metabolism, which is looking at genes primarily expressed in the liver that really don't have anything to do with the brain per se, so that's not part of this discussion. But when we talk about genetic testing, a lot of times I hear a confusion between GWAS, which is a research tool, and it's really looking at additive small effects of very common variants, versus really clinically available diagnostic genetic testing for rare, highly penetrant variants. And we have a lot of experience with diagnostic genetic testing, and there's a lot of research experience with GWAS. Today, I really am going to talk about diagnostic genetic testing, those variants that have major impacts and large effect sizes in and of themselves. So we have a lot of experience, as I mentioned, primarily in the pediatric realm, and I will talk about how the genomics is now informing what we should be thinking about in the adult realm. For the geneticists in the audience, I see fingers pointing there, you're probably trying to figure out the syndromes that all of these individuals have. Every one of these individuals has a developmental disorder and an underlying genetic etiology. There will be a test at the end. Okay, so let's define some terms. Neurodevelopmental disorders, this is the latest terminology, I guess, for that group of conditions that happen during the developmental period and result in impairments in physical, learning, language, or behavior areas. We've also referred to these as intellectual and developmental disabilities in the past. We talked about this as mental retardation. The nomenclature seems to be a bit of a moving target. Likely because of the stigma associated with these conditions. And so over time, terms like mental retardation, in English at least, has become pejorative, and so they changed it to something else. I'll get back to stigma in a little while, because I think identifying genetic etiologies, in my experience and ongoing experience, is one way to really combat the stigma that goes along with these brain disorders. So when we talk about neurodevelopmental disorders, you know, the common examples we talk about are ID and autism, CP, etc. But there are many, many others that come under this umbrella, starting in the developmental period and affecting brain disorders or brain function. And these are all clinically and behaviorally determined. So, you know, they're etiologically highly heterogeneous, and the primary known etiologies are genetic, and there is now a well-known significant contribution of genetic rare variants to causation in neurodevelopmental disorders. You know, as I said, back in the day, we were relying on a 3% diagnostic yield from chromosome studies. We now, for some disorders such as intellectual disability, have at least a 40% clinical diagnostic yield from exome and microarray. So moving to psychiatric disorders, of course there are childhood psychiatric disorders such as autism and childhood psychosis, etc. But really when the general public thinks about psychiatric disorders and when people in genetic counseling think about psychiatric disorders, they really are thinking about adult onset mental health conditions such as schizophrenia, bipolar disorder, etc. And, you know, as has been pointed out this morning as well, you know, these are behaviorally diagnosed conditions using consensus clinical criteria from the DSM. They were never intended to emphasize etiology, and so when you think about psychiatric diagnoses and the diagnoses that we strive so hard to make clinically, there are many underlying causes, and that's where kind of this context of genetics comes in. So for other symptoms in medicine, generally, when somebody comes with a constellation of symptoms, one tries to find out the underlying etiology. That is part of what happens in medicine, and it certainly is part of what happens in clinical genetics. And so doing genetic testing for somebody with a developmental or a psychiatric disorder is no different. I mean, when you're doing those diagnostic tests, you're trying to figure out the underlying etiology or cause. So one of the tools for genetic counseling is to take a very detailed family tree. And as I mentioned, you know, we kind of divide things into the neurodevelopmental disorders during the early with developmental period, pediatric populations, and then we talk about psychiatric disorders, and very often focus on adult psychiatric disorders. Unfortunately, in real life, when a family shows up for genetic counseling, it is not quite so clean. So in this representation, the circles are the females, the squares are the males. This is a classic kind of four-generation pedigree that I would take of a patient coming in, for example, with developmental delay. So. Oh, the cursor doesn't work. So little boy there is presenting for developmental delay. And really one of the reasons, the primary reason we take such a detailed pedigree in genetics is to look for patterns of inheritance. We are trying to figure out, is there a pattern here, which will tell us how this is being passed down in a family, and if indeed it is being passed down at all. And in this family, mom and dad come in and their second child has developmental delay. And then mom tells me she has 3 sisters, and one of her sisters has a son with epilepsy and autism. She also has an uncle with intellectual disability and epilepsy. She has a maternal aunt with a bipolar disorder, and her own mother has major depression. She herself has anxiety, probably because there's so many DSM diagnoses going on in this family. But this is actually not an untrue pedigree. I take family trees for a living, and these are not unusual. And of course, because it takes 2 to tango, on the dad's side of the family, he has a brother with autism, and he has an aunt with schizophrenia. I defy you to find a pattern there. There is no pattern if we are basing these on DSM diagnoses, yet we try to find patterns. So in our world of genetic counseling, we start color-coding things, because that's why we're taking a pedigree. So then I start putting green in here for intellectual disability, developmental delay. Bipolar disorder seems to warrant its own quadrant, and epilepsy will get a different quadrant, and then schizophrenia, let's put a quadrant in for there, and there's still no pattern. Now I've run out of quadrants, so now I've got lines for autism, and then I start using just a generic symbol for garden variety things like anxiety and depression. And I literally have taken hundreds and hundreds of these types of pedigrees in my career, and I remember back in the old days saying, well, you know, you've got a lot of stuff in the family, but it really isn't related to each other. These are all distinct disorders. It's embarrassing, but I would say this. And the family would say, but how could this be? We've got all these brain disorders going in the family. How is this possible that it's unrelated? We know a lot more now. We have better tools than we had in the past that have uncovered now deletions and duplications that we couldn't see on a chromosome study. And now with next generation sequencing, whether it's whole exome or whole genome sequencing, we're really getting down to the genetic code and seeing differences at the level of the sequence. So if we're looking currently at genetic etiologies of neurodevelopmental and psychiatric disorders, we see that we can find single gene disorders and copy number variants in almost half of people with these brain disorders. And in the other half, you know, a lot is still unknown. There's a lot of work being done on polygenic risk scores, which may actually hold promise in the future for helping us understand those common, very, very small effect size variants that together can increase risk. The diagnostic yield of clinical microarray for ID, it's 15 to 20%. For autism, it's 10 to 15%. Epilepsy, schizophrenia, these are all numbers that are quite significant. And yet I hear again and again from my colleagues in psychiatry, oh, well, it's just rare people who have those genetic disorders. You start adding this into whole exome sequencing, and now a genetic etiology can be identified in at least 40% of ID, 35% of ASD, epilepsy, etc. So we're there. We have very high collective diagnostic yields for certain disorders. We've been saying for many decades regarding rare genetic disorders that they're individually rare but collectively common, and I think we now have the evidence that that is absolutely true. So yes, they are individually rare, but they're also giving us insights, as the previous speaker mentioned, on treatments and other areas for future research. The other really important thing to note is that it's been shown over and over again now with studies of large populations with CNVs and also with single gene disorders that there's a high degree of variable expressivity for copy number variants, for example. So on the left here, you see the most common deletions that are found in samples sent for genetic testing, clinical samples for genetic testing. So, and what you see across the top there are the indications. So the 22q11 1.2 deletion, which many people know about because it's relatively common, is seen in diagnostic laboratories with an indication of ID. Sometimes it comes in with an indication of autism, sometimes it comes in with an indication of schizophrenia, sometimes epilepsy, sometimes all of those things, right? And so if you look at all those other CNVs there, again, across the board, you're seeing the same suspects of brain disorders where they're turning up in people with a variety of different conditions. The same is also true for single gene disorders. Again, here are a number of different single genes which can manifest in these different ways. So if we look again at this puzzling family history of a developmental brain disorders or dysfunction where there's something going on that's affecting brain function, we didn't have the tools back then, but this is an actual pedigree with a 15q11 3.3 deletion, which is known to manifest in a variety of different ways, including developmental problems, generalized anxiety, bipolar, ID, and in some people, maybe with some subclinical features that do not rise to the level of a clinical diagnosis, but who may report, I really struggled in school, or I had some seizures when I was a kid, but I outgrew them, I don't have epilepsy now. So the concept of developmental brain dysfunction, sometimes also referred to as developmental brain disorders, or DBD, these are a wide range of neurodevelopmental and adult psychiatric conditions that overlap in symptoms and etiology. And we now know in psychiatry and also in developmental medicine that comorbidities are the rule rather than the exception. Well, why is that? Because you have a brain that's got some sort of dysfunction going on, and depending on how it manifests, it could get diagnosed in a variety of different clinical ways. That should not be surprising. We also know that the same genetic underpinnings result in different developmental and psychiatric diagnoses, even within the same family. Apparently, the genome hasn't gotten the memo that we have a DSM that we came up with and we hold so dear to our hearts. And the DSM obviously has its importance, but you know, it's not consistent with the underlying biology as we're learning about it. So we're starting to see that this range of developmental brain dysfunction, due to the same etiology, it reflects the variable expressivity of brain effects. It's not so much that a disorder is only penetrant for schizophrenia 25% of the time. So let's take 22q11 1.2 deletion as an example. It causes schizophrenia 25% of the time, but it can also cause many other things in people who don't have schizophrenia who have the deletion, such as autism or bipolar disorder, etc. So it's really a variable expressivity of the CNV versus non-penetrance, which is very categorical. And so it's great to hear people this morning talking about the need for studying quantitative traits, really, because if you're only looking at things categorically, I think we miss a lot of what's going on. So what about genetic testing and counseling, practically speaking, from a clinical standpoint? Well, we know there are well-established guidelines for pediatric populations with neurodevelopmental disorders. A lot has been talked about today with chromosomal microarray and the indications for children, for example, who have autism or intellectual disability. Whole exome sequencing is also being used quite widely and starting to be used as a clinical tool in the absence of any diagnosis from CMA. We also do Fragile X testing just because it's relatively inexpensive and can also lead to a variety of different presentations. We also have a lot of experience in pediatric clinical settings with DBD diagnoses, so developmental brain dysfunction, in parents. When parents come in with a child who gets diagnosed, let's say, with a 1q2 1.1 deletion, okay, we may go back, we always do in genetics, and check the parents, and one of them may have that. And then that parent comes in and says, do you think this might be why I've had bipolar disorder and I struggled in school? And then we talk about that parent. So this idea of returning psychiatric genetic diagnoses to adults with psychiatric disorders, it seems like it's new and people have a little bit of trepidation here. I can tell you this has been going on for decades. I do a lot of work with Fragile X. Many mothers of boys with Fragile X have psychiatric disorders that we now can trace back to their Fragile X premutation. We've been doing this clinically. However, if that mom of a child with Fragile X presented herself in psychiatry, adult psychiatry, with symptoms of schizoaffective disorder, for example, we would not do genetic testing on her to try to explain. There's increasing use of CMA and WES, whole exome sequencing, in clinical and research settings, but there's really a lack of recommendations for genetic testing in adults, even with neurodevelopmental disorders. You know, it's, at least in the States, insurance companies will say, yes, we'll pay for you to do whole exome or chromosomal microarray, but oh, not in a 30-year-old with ID, just in a 5-year-old, you know, as if it has less importance. So as we're doing a lot of exome sequencing and as medicine moves in that direction, we are going to start finding these CNVs incidentally. And what are we going to do? Just ignore them? Oh, we're not telling them that. We're not going to tell them that we found this thing in their, you know, as a secondary finding. And the reason for that is because we've chosen, as a field of genetics right now, to only return things that are medically actionable in a very, very strict sense. So cancer, and cardiovascular disorders where increased surveillance can be done, et cetera. But we will get to a point where we may have to question, you know, if we find a chromosomal deletion, a pathogenic deletion, for example, in somebody with a psychiatric illness, do we withhold that information? Maybe they were having that testing done for something totally different, and we realize now that they have this deletion. So this has a lot of implications for future research testing and also as we use more broad genetic testing in medicine clinically. And I would argue, and I'll show you through the next few slides where I talk about some actual patients who've had results returned to them, that even if they're not medically actionable in that very, very strict sense, knowing a genetic etiology is clinically quite relevant, and there are implications for personal utility and reproductive planning as well. Not quite so easy to wrap your hands around as, you know, we're going to do increased surveillance for cancer, but nonetheless very important to the patients themselves. So to look at this further, I'm going to describe some of the findings of a large community health population project called MyCode at Geisinger. Geisinger is it's actually the largest rural health system in the United States. It's in central Pennsylvania in the US. And we have a project that's been going on for a number of years called MyCode, where anybody who seeks medical care at our facility, so it's an unselected healthcare population, is invited to participate. We have a high rate of participation with over 200,000 participants. And we get samples of blood and saliva on them, and we also have access to their electronic health record. And Geisinger was the second adopter of electronic health system in the United States because we're so rural, we had to link all of our doctors together, right? So we were the second one in 1996. So we have an average of 14 years of electronic health record data on individuals in our health system, and now we have some exome data as well. And so we're returning results for all the medically actionable disorders, the 59 disorders that are recommended by the American College of Genetics and Genomics to be returned because they influence medical care. But we're also now returning, as part of a separate project, copy number variants and single gene variants that are known pathogenic that can lead to developmental brain dysfunction. So we will have analyzed 145,000 exomes by the end of this month, and again, linking those together and getting those medically actionable results out to patients, but also as part of a smaller project called the Gene Dosage Imbalance in Neurodevelopmental Disorders under Krista Martin and David Ledbetter. We are returning results for DBD-related variants to individuals and their families. So for this discussion, I'll talk about 33 pathogenic recurrent copy number variants, things like the 22q11 1.2 deletion, the 1q21 deletion duplication, ones that are well-known, well-established, pathogenic, very large effect sizes on brain function. And what we found in this unselected healthcare population is that almost 0.8% of the population had a pathogenic copy number variant. And only 12.6% of them, most of them being adults, older adults, knew that they had a genetic diagnosis. So we are returning these now to people who didn't know they have these diagnoses. And here are the different deletions and duplications in our list that we're returning. And when we return these results, you have to understand when people consent for this study, what they're told is that, you know, you are consenting to allow us to look at your electronic health record and your genomic data, and we will contact you if we find something that we think is clinically relevant that you may want to know about. And, you know, we talk about examples of, you know, cancer predisposition variants, et cetera. And we also say if there's anything else that we think that might be important for you to know, we'll be in touch with you and give you the option of learning about that. And we believe that returning these DBD-related genomic variants is quite important. There are potential challenges here because historically, DBD is associated with significant societal stigma, not the genetic finding, but the developmental brain disorder itself. And so the discussion requires a skilled hand, you know, to say, hey, you know, we see in your chart you have bipolar disorder or you've had intellectual disability. You know, those discussions are something that we've talked about and trained quite carefully before we return them. The identified adults in our MyCode cohort may have DBD symptoms without a clinical diagnosis, so maybe they didn't get a diagnosis of depression, but then when you meet them, they tell you about all the problems they've had. And primary care providers are generally very unfamiliar with these variants, and we're providing information to their doctors as well, so we have to do a little education there. Some people may have cognitive and psychiatric symptoms that can impact disclosure. But we think the benefits are that you can get an unbiased, comprehensive picture of rare variants across the lifespan. And this is a unique contribution to research on the value of genetic diagnosis for adults. We see there's a positive benefit to many for having a medical explanation for their lived experience with these brain disorders, and in some cases, significant changes in clinical management. So the previous speaker spoke about the 1q21.1 deletion, which is a known pathogenic disorder. And this person is a 62-year-old woman. And this disorder that we identified in her has the number of different features which are listed here. And when we looked in her chart, what we found in red here were these are the features that she manifested. She had a generalized anxiety disorder, was on medication for mood disorders, and short stature. We asked her to come in to talk about the deletion that we found, and she said she completed high school, but she wasn't a good student. She came to the session with her 2 adult daughters, and it was really a wonderful family discussion. It was a very active discussion about this. She said she was always sensitive, diagnosed with generalized anxiety, periods of depression, treated with medication, but always worked very diligently. She had various factory jobs. Her daughters were joking that they felt she had OCD in that popular thought. She said she is such a fastidious housekeeper. Everything has to be neat and in its place, and if you do not put it there was hell to pay. So it was really a neat kind of discussion. She lives with her husband, her mother who has dementia, and she has a daughter. One of the daughters has visual impairment and also a grandson. And here's the pedigree. So here's our woman here with the arrow. She also had cataracts in her 50s. Her mother had anxiety and mood swings and now has dementia in her 70s. This woman had a daughter who died at birth of a cardiac anomaly. Her 3rd daughter, who came to the session, had microphthalmia, or small eye, and a coloboma, or eye defect, and learning difficulties, depression, and anxiety. She did go to college, but is unable to work and is on disability, and she has a son who also lives with the woman. There's a 3rd daughter there who has bipolar disorder, who's estranged from the family, and she has a son with OCD, and the grandson is in touch with his grandmom, etc. This one daughter here doesn't have symptoms herself, but has 2 daughters who have learning problems in school. So we discussed the 1Q21.1 deletion, talking about one cause, can have multiple effects on the brain. And really, all of these discussions include a discussion that the brain is an organ just like any other, you know. You can have different types of heart defects that you're born with, you can have different kinds of things, but somehow when it's the brain, people start to feel a little worried about it or anxious or embarrassed. And so we try to put that out of the way right away. Talked about research opportunities now that we know that this woman has this deletion, gave her literature, particularly wonderful literature and resources from the Simons Foundation, and a medical plan to inform her primary care doctor about the diagnosis and then cascade genetic testing for the family. And when we did cascade testing, here's the woman here in red, what we found is that her daughter with microphthalmia and learning difficulties also had the 1Q21.1 deletion, and her mother also had that deletion as well. I should mention here, this daughter did not have the deletion, okay? So the learning disabilities in her daughters are not related, which was interesting. We don't know, but we suspect that the daughter who died of a cardiac anomaly probably had the deletion. Cardiac anomalies occur in about 25% of individuals with this deletion. So this woman's reaction was that she recalled consenting to MyCode and the general purpose. And we had a very active family discussion involving the daughters. And they were extremely enthusiastic about having a diagnosis. Amazing. It explains a lot. She was particularly relieved to think that this might be an explanation for her 1st daughter who died at birth, because she had been told it was due to bendectin, a drug that she was taking for nausea during pregnancy. And she'd carried that guilt around for many years. She also mentioned, we never talked about this before. You know, all this stuff going on in the family, we never talked about it. So thank you so much for getting this diagnosis out. And we've been talking more than we ever did. And she also said something that I think is very telling. She said, you know, psychiatrists are always saying, yeah, well, obviously you have a family history, things run in families, but it's so vague when you say that. But for you to sit here and show me my lab report that I have a deletion of 1Q21, that is very, very different. And I think that has been our experience so far. I'll share one last scenario with you. We've so far returned 126 results. We're actually writing this up for publication soon, and the overwhelming response has been quite positive. The second result was a 20-year-old man with a 17q12 deletion. This is a condition with a variable neuropsychiatric phenotype, but also very much associated with renal cysts and diabetes, RCAD as it's called, because of a particular gene in that region. And so individuals with this are at risk for not only renal disease, but also maturity onset diabetes of the young, or MODY. They can have a variety of other things. And this young man, at 20, had autism, normal and average IQ, renal cysts. He had some congenital anomalies. and some eye abnormalities, but was generally pretty healthy. He had been identified as having renal cysts as a young child because he was adopted, and it had been known that his biological mother had polycystic kidneys and psychiatric disability, which we now can assume is due to the 17q12 deletion. He has a biological sister, he had some delays, lots of interventions during school. He graduated high school. He's thinking about community college, lives with his adoptive parents, who his mother in particular is quite protective of him. But he drives, he works as a kitchen staff in a restaurant, and he enjoys playing computer games and socializing with other gamers. So we reviewed, again, what this 17q12 syndrome is, discussed that the brain is nothing to be ashamed about. It's just like any other organ. And this really actually went over he got a kick out of that idea. It's just an organ, right? I plugged him into the 17q12 interest group on Facebook, which is quite active. There's also a phenotyping research opportunity through our center, which he was very interested in participating in. Medically, provided info about his diagnosis to his primary care physician. They were following him for cysts, but now they know this is cysts associated with 17q12 deletion and not necessarily autosomal dominant polycystic kidney disease. And also got a referral from his primary care doctor to endocrinology. He's got at least a 50% risk for developing MODY5. And also a neurodevelopmental assessment to really better characterize the nature of his developmental brain disorder. He is 20, and as things evolve behaviorally and psychiatrically, he is at risk for psychosis and other things potentially in the future. So we certainly want to make sure he's plugged into the right resources. He remembered consenting to MyCode and the general purpose of it. He was an active participant in the discussion. He came with his adoptive parents. He said he was very nervous when he originally got this vague letter asking him to call about the results. He's saying, I hope you're not going to diagnose me with autism. Just again showing the stigma of these disorders. But then he was relieved and excited to know he had this rare, exotic, genetic thing. That was not stigmatizing at all. He had to pronounce it again, 17q12. Yeah, I really like this. And I explained it's 17q12, not 17q12. Okay, there's a big difference there. So his reaction was, this is important information. He said that multiple times. It's exciting. I want to sign up for research if it can help someone else, which is, again, a theme that we saw again and again. And then he wanted to participate at our center for research. He does drive, but of course his mom was hovering and saying, well, I'll drive you there. And he said, I can drive myself to the research, Mom. But overall, it was very, very positive for him, and he continues to be actively involved and continues to be very almost proud of his genetic diagnosis. This is not at all as stigmatizing as the other diagnoses he had. So I'll just skip to the conclusions here. So rare pathogenic variants, and I'm just talking about the copy number variants here. We haven't even started looking at the single gene variants, which we will no doubt find in these populations. They have large effects on brain function, and they make up an increasingly significant proportion of DBD etiologies. It is really interesting to hear this morning trying to parse out organic versus not organic. I have to say, what you're saying is known versus unknown etiology. That's because we were in the organic, not organic in intellectual disability for years, and now we realize it's still an organ, it's a brain, it's got fundamental underpinnings that are medical in nature. The disclosure and identification of these variants is a clinically and psychologically important outcome for adults with DBD, and medicalizing these disorders potentially reduces stigma. I feel very strongly about that. I felt strongly about that before even going into this. Years of returning results to these patients. I do know people have some fears. How are they going to react to a genetic diagnosis? Do you really think a genetic diagnosis is going to be more stigmatizing than a psychiatric diagnosis? And it's not been my experience. But I think it is worth, as Dr. Degenhardt said, something to discuss. We need guidelines for clinical genetic testing in adults for neuropsychiatric disorders. We don't know where to go with this now. This was a research project. And we do know that these variants will be found increasingly as clinical and research projects become more common, and these are identified as incidental findings. I want to thank all my colleagues at Geisinger and for the many families and individuals who have made our work possible. Thank you very much.